All right, morning everyone. Apologies for the delay. I'm gonna have to talk really, really fast, but I hope that you find some of this talk a little bit interesting. So I'm gonna give you a bit of a refresher on ARVs. I'll talk a little bit about things that have changed, about some things that are new and sort of newish. And I'm sure that many of you will have seen that the latest national HIV guidelines have just been released on the 28th, which was last Friday. And of course, I had prepared at least some of this talk before the 28th. So it was kind of annoying that it came out on Friday. And it's like they couldn't have waited until next week. Anyway, but this talk isn't really a guideline review because, you know, all of you can read. So I hope that some of this will at least be of interest to you. All right, so do we think that ARVs are still important? It's an old disease now. Is it something that we still need to know about? Is it, you know, is it very easy? Do we need to even care? So just a reminder that it is a disease that is killing people, and there are things, and we still need to really focus on it here and in the world. It's killed 40 million people since we learned about it. In 2021, about 650,000 people died of HIV-related illnesses, and 1.5 million were newly infected, which in this day and age is kind of scary. The numbers do show a decline from peaks in earlier years, but it still means that there are 38 million people living with HIV at the moment. The majority of those people are in Africa, and 1 million or 1.7 million of them are children globally, not just in Africa. Also, very worryingly, in the last few years, certain regions have shown an increase in the number of new infections. The regions of Eastern Europe and Central Asia, the Middle East and North Africa, Latin America have all shown increases in the number of new infections annually in the last decade. That increase in new infections also appears to be occurring in Asia and the Pacific region, which is the most popular region populous region in the world. It's probably a result of humanitarian crises, economic crises, and obviously COVID-19 has affected delivery of service, and many people have been pushed into poverty as a result of all those crises. In our region, in Eastern and Southern Africa, we are still seeing a decline in the number of new infections, but the progress has slowed over the last decade. And overall, 38 countries have shown an increase in new HIV infections since 2015. There are obviously certain groups that are at high risk of HIV acquisition, people who inject drugs, female sex workers, gay men and other MSM, transgender women. But I think it's important to bear in mind that women in general are disproportionately affected by HIV. So that very large green dot there at the bottom, that is the number of women over the age of 15 living with HIV in South Africa. That's 5 million out of an estimated 7.5 million people living with HIV, or 66% of the total. So while it's important to recognize that there are more specific vulnerable groups, it's also important to realize that women are a vulnerable group in and of themselves when it comes to planning interventions. Okay, so we are now 40 years into the AIDS pandemic, and we have fortunately made great strides when it comes to treating this disease. The drugs work, the options are pretty good. Prevention gets better and better. We've got long-acting therapies now that are available for both treatment and prevention. And medically, things look good, but addressing the inequalities, as mentioned before, remains a priority to ensure that those medical options are appropriately administered. So the advantage of successfully treating and preventing HIV, sorry, that's very tiny and you probably can't see it, can't really be disputed. It's not just about saving lives, but it's about restoring normality to those lives. So allowing people to be well, to work, to enjoy relationships, to have and care for their children, and to do all those things without any stigma or discrimination. So the 90-90-90 targets of the previous decade have been modified to the 95-95-95 targets, which doesn't roll off the tongue as easily. I think they should have left it as 90-90-90. But now what it means is that we want 95% of people to know their HIV status, 95% of those who are HIV positive to be on treatment, and 95% of those on treatment to have suppressed viral loads. So in South Africa, as far as achieving the 95-95-95 targets, the Eastern and Southern African regions compare quite well to the rest of the world in achieving those targets. In 2021, 94% of people who had HIV knew their status, 75% of those were on treatment and 67% of those on treatment were virologically suppressed. If we achieve the 95 targets, it means that 90% of people who have HIV will be on treatment, and 86% of those people will be virologically suppressed. Okay, so what are the means that we have available for achieving virological suppression? So there are several classes of antiretrovirals. Most of us are familiar with the NNRTIs, the NRTIs, the protease inhibitors and the integrase inhibitors. These are the agents that we kind of use regularly and that we're very familiar with. They're less mainstream options like the fusion inhibitors, the CCR5 antagonists like Maraviroc. They've been available for some time, but we don't really use them in clinical practice, and certainly not in South Africa. Then there are these new fancy agents, some monoclonals. So the HIV world has caught up with everybody else, and we now have some monoclonals. And the post-attachment inhibitors, capsid inhibitors, and so on are entering the arena. So this is a simple list of the currently available ARVs. The traditional approach has always been to choose 3 drugs from at least 2 different classes. But as the robustness of the drugs improve and the medical complexity of the patients increases, we are looking at simplification strategies, and it's now becoming apparent that 2 drug regimens are probably sufficient for suppressing viral replication. Okay, so the integrase strand transfer inhibitors are pretty much the anchor drugs for most regimens at the moment. They obviously catalyze the process by which viral DNA is incorporated into the host genome, prevents the strand transfer of the viral DNA into the host cell DNA. Virological failure with the earlier agents, elvitegravir and raltegravir, when you failed those regimens, you usually failed with integrase inhibitor mutations. The newer generation integrase inhibitors, bictegravir and dolutegravir, it's very uncommon to have an integrase inhibitor resistance mutation when you fail that regimen. In other words, what that means is that when patients fail the regimens containing those 2 integrase inhibitors, it's for reasons other than resistance. So it's related to adherence or absorption or drug interactions or something like that. In general, this class of drugs is well tolerated. They are associated with weight gain. The average is about 3.5 kilograms. Nobody really knows why yet. And prescribers are obviously concerned about weight gain. Patients are concerned about weight gain. In our setting, a significant portion of our patient population complicates their recovery from HIV with excessive weight gain. So it is something that we need to be concerned about. But overall, the potency of bictegravir and dolutegravir kind of outweigh those risk factors, which can be managed often with lifestyle change. They do have some CNS side effects, a bit of insomnia, dizziness is described. Depression and suicidal ideation has been described, but really very rare. So what about dolutegravir? So dolutegravir is currently the drug of choice for first-line regimens. The standard dose is 50 milligrams. The dose needs to be adjusted if you give it with rifampicin or certain other drugs that it may interact with. Always a good idea to check drug interactions when you're prescribing dolutegravir. If you can, try and adjust the other medications, the concomitant medications, in order to preserve the option of the fixed dose combination, because obviously it's cheaper, it's easier to get, it's widely available, rather than having to use the FDC and then boost the dolutegravir. For something that's short-term like TB, it's more reasonable to say, well, we'll boost the dolutegravir and give normal TB treatment. But if there are other interactions, consider maybe adjusting those other agents. If you have a patient who is treatment experienced with integrase inhibitors and failing therapy, and certainly if there are more than, so if they're failing therapy and they have used integrase inhibitors before, then you might need to boost. So you might need to use double the dose. If the patient has more than 3 integrase inhibitors, then you need to avoid using dolutegravir. Okay, so in South Africa, it's formulated for TDF and 3TC, which we commonly call TLD. It also comes in combination C, which can be used with renal disease, but obviously the 3TC is a full dose for patients with renal disease, and it comes alone as a 50 milligram tablet. Interesting, TLD is not available in many other parts of the world. We use it here and we use it in large volumes, but in many other parts of the world, it's not available. It can be used in a standard dose in anybody over the weight of 20 kilograms, adolescents and adults, obviously. It can be given with or without food, and you can give it at any time of the day. The previous 2019 guidelines mentioned neural tube defects. That comes from, and making sure the women who are of childbearing potential get counseled and that they're on effective contraception. That came from an early study, the Tsepamo study in Botswana. And it appeared from that study early on that there was a 12 times risk of neural tubes defects in women. That did not carry through to the end of the study, and by the end of the study, there appeared to be no difference in neural tube, the incidence of neural tube defects between groups. So in 2021, the National Department of Health said that you can give dolutegravir to everybody, men, women, it doesn't matter who, and that obviously has been incorporated into the new guidelines. And then also since the release of the 2019 local guidelines, the guidance for switching ART has changed. Before, we needed to have a viral load that was undetectable in the last 6 months in order to be able to change from their regimen that they were on to a dolutegravir-based regimen. That is no longer an issue. So the in 2022, the Clinician Society said that because the switch to dolutegravir-based regimens was taking such a long time that the HIV Clinician Society reviewed the data and said it doesn't appear that it's actually necessary. So regardless of whether your viral load is suppressed or not, if you change to a dolutegravir-based regimen, you will usually suppress your viral load. So the Nadia trial also which was done in South Africa, showed that even if you're switching from TEE and you are failing on TEE, if you switch to TLD, you will suppress again. And it appears that recycling TDF and 3TC into that dolutegravir-based regimen is actually better than using AZT 3TC with dolutegravir. So now so there's a little statement at the bottom there that says that children need to have their 6-monthly viral loads and so on. That was from last year, and in the new guidelines that has changed. The same applies to children, that you don't need a recent viral load in order to change. All right, so the new guidelines that have been released are really just kind of catching up with the WHO guidelines from 2021. It includes this table. There's essentially only one group of people that cannot receive dolutegravir, and that's neonates. For whom the recommendations are raltegravir, nevirapine, or lopinavir ritonavir with 3TC and AZT or abacavir. So this is the WHO, this is a table from the WHO guidelines. The South African guidelines have removed AZT entirely from our armamentarium. So the WHO says use AZT in kids because abacavir syrup is hard to get hold of. We don't really have a difficulty getting hold of abacavir syrup, so we have chosen abacavir over AZT. All right, so this is basically a snapshot from the new guidelines of the latest changes, which we've gone through. There's now a dispersible tablet available for children, so anybody over the age of 4 weeks can now get a dolutegravir-based regimen. All right, so then dolutegravir is also approved for use with 3TC alone. So a 2-drug regimen, it is approved for initiation of therapy in some other countries on the basis of 2 trials. Those 2 trials were called Gemini 1 and Gemini 2. And they randomized treatment-naive patients with viral loads of less than 500,000, no hepatitis B, obviously, because there's only a single drug that treats Hep B, and no integrase inhibitor resistance mutations. So these were patients who had to have a pre-treatment resistance profile. And they got either dolutegravir 3TC or dolutegravir FTC TDF. And the results in both arms were comparable all the way out to 144 weeks. It does appear that in patients who have a CD4 count of less than 200, it doesn't work as well. So based on the Gemini trials, there is no restriction for a CD4 count, but many of clinicians overseas who use this regimen are kind of reluctant to use it in patients who have CD4 counts of less than 200, although there's no restriction in the registration for the use initiation of this option. And obviously a 2-drug regimen becomes more and more attractive because As patients get older and they're using many more medications and there's drug interactions and so on, the fewer drugs you give for HIV, the more likely you are to achieve success. All right. So it's important to remember that dolutegravir is a substrate for cytochrome P450. The major interaction, as we mentioned, to bear in mind is rifampicin. You need to double the dose of dolutegravir. Other things, anticonvulsants, metformin as well. You need to remember the interaction. And also just to remember that when you are dose adjusting dolutegravir with rifampicin, you have to remember that it takes about 2 weeks for the effect of the rifampicin induction on the cytochrome P450 system to wear off. So you can't stop the TB treatment and the extra dose of dolutegravir on the same day. You stop your TB treatment, you wait 2 weeks, and then you convert to the FDC and you take away that extra boost dose of dolutegravir. Okay, so bictegravir is not available here. It was approved in 2018 by the FDA. It comes as a co-formulated tablet. There's only a co-formulated tablet available. It comes with emtricitabine and TAF. It's only approved for treatment in treatment-naive patients or in switch for stable patients who have no history of treatment failure and who have no mutations affecting the components of the fixed dose combination. It's not approved for treatment in treatment-experienced patients or in those who are failing therapy because there's just very little data. It may become approved in those patients in future, but at the moment there is insufficient data to use it in those groups. Clinicians who use this combination have used it outside of those recommendations, and it seems that it does retain activity in the presence of mutations conferring resistance to NRTIs. It's similar to dolutegravir, and it has been used successfully in practice in patients who have detectable viral loads. Important in our setting that it is completely contraindicated for the use with rifampicin. So, you know, in our program, it wouldn't be a great option. It's the secretion of creatinine in the same way that dolutegravir does, and that results in a decline in the calculated GFR. It is not related to a decline in actual GFR. It's not approved for kids below the age of 2, but those studies are underway. Okay, so raltegravir was the first integrase inhibitor approved for the treatment of 1,200 milligrams once a day in patients who are suppressed or who perhaps are treatment naive as well. And it, you know, if you can avoid using it with rifampicin, rather avoid using it, but you can double the dose to use it with rifampicin. Better tolerated than PIs, also associated with weight gain, achieves better virological suppression than efavirenz, but has a lower barrier to resistance than the newer integrase inhibitors or the PIs. And it doesn't come as a fixed dose combination. Okay, and then I'll just mention elvitegravir to say that it's been discontinued by the manufacturer. And then cabotegravir we'll discuss a little bit later. It's a new integrase inhibitor that is quite exciting. All right, so what about tenofovir? So obviously we have a number of NRTIs available. The vast majority of agents of regimens will include tenofovir rather than the other NRTIs. So we are familiar with tenofovir disoproxil. I'm not really sure how to say that. I've never really learned how to say it. I think it's disoproxil fumarate, which we call TDF, and tenofovir alafenamide, which we call TAF. Both of them are prodrugs of tenofovir, which is converted into its active form, which is called tenofovir diphosphate inside the cell. The difference between TDF and TAF is that TDF is rapidly hydrolyzed in the plasma into tenofovir. TAF remains relatively stable in the plasma and is hydrolyzed within the cell into tenofovir. So basically what that means is that you give 300 milligrams of TDF, that gives you more tenofovir in the plasma and less in the cell, whereas you give 25 milligrams of TAF, that gives you 90% less tenofovir in the plasma and substantially higher tenofovir diphosphate in the cell. And because tenofovir is the active drug that metabolize in the plasma, that's the component that is associated with tenofovir toxicity, so renal toxicity and bone toxicity. So if you give TAF and you have less in the plasma, the lower the toxicity from the antiretroviral agent. Okay, so either tenofovir or assume when I say tenofovir, I mean TDF. Either TDF or TAF form part of the NRTI backbone in the vast majority of guidelines for first-line initiation. There are two major guideline issuing bodies, the Department of Health and Human Services in the US and the European AIDS Clinical Society that include a backuver. But of the 17 first-line options for triple therapy across 4 guidelines, there are only 2 that include anything other than TDF or TAF. So what restrictions apply to the use of these 2 agents? And why would you prefer one over the other? So obviously we're aware of the renal toxicity and the bone mineral density loss associated with tenofovir. The use of TAF doesn't eliminate the risk of these toxicities, but the side effect is definitely more commonly seen with TDF. And the risk for renal toxicity varies across studies between about 2% and 10%. It is associated with new and worsening renal dysfunction. And it manifests as various things. So you can get a rise in creatinine, proteinuria, glycosuria, hyperphosphatemia, acute tubular necrosis. They may develop Fanconi syndrome. They may get acute kidney disease, and then they may develop chronic kidney disease, which obviously is best avoided. It's most likely to occur in patients who have pre-existing kidney disease, patients who are older, those with advanced HIV, if you've got hepatitis C co-infection, a low BMI, especially in women, and in patients who are using other nephrotoxic drugs. The recommendation is clearly that if a patient has a GFR of less than 60, TDF should not be used. However, there may be circumstances, for example, the patient also has chronic active hepatitis B, and you don't have TAF as an option, where you might want to continue to use TDF. And also perhaps in a patient who's got CKD on dialysis, there's no expectation of recovery of renal function. In those circumstances, TDF can be dose adjusted within that context. It's obviously important to monitor progression of renal dysfunction and proteinuria very carefully. So having said that, if you are using TDF in a situation where the renal function may be compromised, in a resource-limited setting like ours, where the monitoring might be limited and the access to renal replacement therapy, if the patient does develop chronic renal disease, might be limited, then you have to decide whether or not using that tenofovir is worthwhile. So decline in bone mineral density is also linked to TDF. The bone loss is observed, that the bone loss that is seen is generally moderate, and it stabilizes over time with continued use. So the ongoing bone loss occurs up to about 3 years and then stops. So the risk of osteoporotic fracture is associated with ever having used TDF, but not with the cumulative risk, not the cumulative use of TDS. So if you've ever used tenofovir, you might be more likely to break a bone, but if you continue to use tenofovir, that risk does not continue to increase. And the traditional risk factors of bone loss, like smoking and low BMI and age and race and so on, are more closely linked to osteoporotic fracture than the use of TDF. Okay, so TAF, when it came around, seemed to be the answer to all the issues that we see with TDF, and it is certainly associated with less renal and bone toxicity, but it comes with its own set of problems. And the main one is significant weight gain. So that's shown in patients who receive it for ART initiation, for patients who receive it for switch therapy, and for patients who are receiving TAF who are HIV negative, so they're receiving it for PrEP. The ADVANCE trial, which was conducted here in South Africa, was really the first trial that showed that both the integrase inhibitors and TAF were associated with weight gain. So they compared TEE to TLD and to dolutegravir TAF FTC. And they found that the TAF arm was associated with more weight gain than any other regimen. So that's up to about 10 kilograms in Black women, which was the group that was most affected by this adverse event. And the weight gain associated with TAF is probably exacerbated by using it with integrase inhibitors, and the two together result in more weight gain than either one on its own. So the weight gain seems to kind of stabilize at about 2 years and doesn't appear to be ongoing. And people often talk about a return to health weight gain, which is certainly possible in some circumstances. But the thing that's worth considering is whether this weight gain is associated with metabolic complications. And it does appear to be an issue. So it's not necessarily healthy weight gain when people are treated. So switching to a 2-drug regimen is associated with, switching to dolutegravir 3TC in women is associated with some weight loss after weight gain with those regimens, but switching to other regimens doesn't appear to resolve the weight gain, and it doesn't appear to be an effect in men as well. Okay, so I thought it might be useful here to add a slide about managing hepatitis B and HIV because it's obviously linked to tenofovir. The advantage of most of our recommended first-line regimens is that they contain either TDF or TAF and 3TC or FTC. And all of those 4 antiretrovirals have activity against hepatitis B. Treating hepatitis B, similar to treating HIV, is better done with a combination of drugs. So using 3TC or FTC alone, for example, is associated with fairly rapid development of resistance, about 40% by 2 years and about 90% by 4 years. So if the patient qualifies for a 2-drug regimen like dolutegravir 3TC from an HIV point of view, you would probably still prefer to add tenofovir to make sure that the hepatitis B is treated properly. The drug Integrase has some activity against HIV, but it is not an antiretroviral. So you can't, if you are using Integrase to treat the hepatitis B, you have to use a fully suppressive antiretroviral regimen as well. Obviously, treating hepatitis B is worthwhile in patients who have detectable DNA, in other words, replicating hepatitis B. If you suppress hepatitis B replication, there's about a 60% reduction in the development of hepatocellular carcinoma. Remember, when you're stopping hepatitis B active ART, that may be associated with rebound disease or a Hep B flare, and that can result in severe hepatocellular damage. So you need to be careful about that. If you are changing the ARVs to manage the HIV, you must make sure that you are continuing the hepatitis B options as well. And obviously, if there is no choice and you have to stop the Hep B management, you have to be very careful about watching to see whether there's a flare. All right, and what about PEP and PrEP? So the recommendations for post-exposure prophylaxis include an integrase inhibitor and a combination of TDF and FTC. It's important to decide always whether or not that exposure warrants post-exposure prophylaxis. And exposures are defined either as occupational, which is most commonly, a needle stick or a splash, and non-occupational, which is either a sexual exposure or a needle sharing drug use. So in terms of sexual exposure, the risk of acquisition is condomless sex. If you have sex using a condom, that is not considered a high-risk exposure and is not a requirement for post-exposure prophylaxis. And then obviously at the top there is the blood transfusion, which pretty much you're kind of infected. But obviously we can consider that pretty much a historical risk. So what are the other considerations for prescribing PEP? It's time since exposure. So the recommendation is obviously to make sure that the patient who has an HIV exposure receives their post-exposure prophylaxis as soon as possible. There's good evidence from animal models that PEP taken within 24 hours prevents HIV, but efficacy declines after that. And pretty much there's no evidence for PEP after 72 hours. So some guidelines, including our local guidelines, say don't give PEP later than 72 hours after the exposure. WHO guidelines don't include this restriction. And I think when you're dealing with a patient who has had a high-risk exposure and they've arrived 3 days later, it's very hard to say, no, I'm sorry, you're not going to get any post-exposure prophylaxis. But the recommendation is not after 72 hours. Obviously, your choice of post-exposure prophylaxis is going to be influenced by potential drug interactions, patients' comorbidities, the need for laboratory testing, and so on. But generally, the recommended regimens are well tolerated, they're safe, they're efficacious, and it's usually unnecessary to deviate from a standard regimen. Obviously, if a patient is presenting on a repeated basis for evaluation for post-exposure prophylaxis, or they've had more than one course of PEP in the last year, and we assume that means sexual exposure or drug exposure rather than a really clumsy, intern, then that person needs to be evaluated for transitioning to PrEP rather than post-exposure prophylaxis. So if they're having recurrent exposures, they keep coming back asking for PEP, then that's a person who needs pre-exposure prophylaxis. All right, PEP should be continued for 28 days. Many people, particularly medical people, often come and say, can they do a viral load at 2 weeks, or can they do the HIV PCR at 2 weeks, and then can they stop their post-exposure prophylaxis if those results are negative? And that is not an option. You cannot stop your post-exposure prophylaxis before 28 days. There is zero evidence for efficacy if you stop earlier than 28 days. You can stop PEP for 3 reasons, essentially. If the source tests HIV negative, unless you are concerned that the patient is acutely infected. If the exposed person tests HIV positive, so they're HIV positive as baseline, or if the HIV positive patient is virologically suppressed, but that only applies to non-occupational exposure. So if it's an occupational exposure to a person who's got suppressed HIV, that person with the exposure still needs to take PEP. All right, and then sometimes, even if you have a non-occupational exposure and the patient is virologically suppressed, the source patient is virologically suppressed, if that patient wants to take post-exposure prophylaxis, it's reasonable for that patient to take it. All right, so the PEP regimens are essentially standardized. We use 3 drugs. The recommendations are for TDF in combination with an integrase inhibitor. Dolutegravir is preferred. If they're not tolerating the TDF and they want to take something like a Bacavir, then you would have to do the HLA test to determine whether they're B5701 positive. That would be the usual recommendation. And then if that test came back 2 weeks later and they didn't like the tenofovir, they could change to a Bacavir. AZT3TC is generally very poorly tolerated in people taking PEP. And the renal toxicity that we see with tenofovir is usually a long-term thing. It's unlikely to occur within the 28 days of the use of PEP. So really, even with pre-existing renal dysfunction, TDF is recommended over the alternative agents. All right, so PrEP comes in many forms now, including some long-acting agents, but it was really first shown to be effective with a tenofovir-based regimens. TDF is currently, Truvada is currently registered in South Africa for PrEP. It can be taken as daily oral PrEP. It's effective in all populations expected to be in need. That includes adult men and women, adolescents over 35 kilograms, MSM, transgender people, pregnant women, people who inject drugs, and serodiscordant couples. Serodiscordant couples may require PrEP if they're trying to conceive safely and the HIV positive partner is not suppressed or not taking ARVs for some reason. And then ultimately the decision to continue PrEP is based on an individual choice to decide whether or not they want to take it after that the partner becomes suppressed. TAF FTC is approved for daily PrEP in MSM and trans women, but it's not approved in cis women and trans men who engage in vaginal intercourse because the PK parameters in vaginal mucosa are not established. Obviously, the advantages of it apply to PrEP as well. So FTC, TDF FTC is also effective as on-demand PrEP. So that means that if you expect to engage in a high-risk behavior, and you take your TDF 3 days around that risk exposure. It's in MSM and transgender women because higher levels and achievement of a steady state is achieved much faster in the anal mucosa compared to the vaginal mucosa. Achieving effective levels in the vaginal mucosa takes about 7 days. So on-demand PrEP is not an option for cisgender women and transgender men, unless they're only having receptive anal intercourse. And then TDF-based PrEP should not be offered to people who have a clearance than 50. All right, so emtricitabine and lamivudine, essentially interchangeable drugs. They have the same effect on viral suppression. 3TC has been associated with pancreatitis. FTC gives you skin discoloration, but really it's very, very benign drugs. And because they select for the M1A4V mutation, they can be recycled into second-line regimens because they result in hypersusceptibility to AZT and TDF. All right, I'm going to skip over the other two. All right, so what about efavirenz? Is it still a drug that we should use? So efavirenz is actually still a good drug. It's potent in patients who are treatment naive, in patients who have high viral loads. It still works well. It's pretty durable. For those of us who work in HIV all the time and we're switching patients to the new regimen, most of the time we're switching patients from TE to TLD with suppressed viral loads. So the vast majority of patients actually suppress quite well on TEE. There is an option to use a lower dose. It does come co-formulated as 400 milligrams instead of 600 milligrams, and that does seem to be associated with fewer side effects. But really, the reason that we're changing from efavirenz to dolutegravir is because of the lower barrier to resistance from efavirenz and the increased side effects that we see with efavirenz. So what about nevirapine? So the question about nevirapine is that most people in the world are not going to use nevirapine. It's not as bad as its reputation. A lot of people say that it's just too toxic to use and nobody uses it. But the fact is that it's just been superseded by ARVs that work better and are less toxic. So there aren't many situations in which we still need to use it. So for adolescents and adults, it's not recommended at all. The WHO says you can't give nevirapine to anyone over the age of 2. The current guidelines for PMTC, which are also going to soon be updated, still include nevirapine as a single agent for HIV-exposed infants over the age of 6 weeks. That's probably not going to change with new guidelines. It applies to all HIV-exposed infants, but some infants are at higher risk of HIV acquisition, and they'll need to get AZT as well as the nevirapine for the 6 weeks. And then some patients, so high-risk infants who are then breastfeed should receive nevirapine for at least another 6 weeks, or until 4 weeks after they've stopped being breastfed. So there is still a place for nevirapine, but it's a small place and certainly not for adult medicine. So what about doravirine? Doravirine is a newer NNRTI. 28 it comes as its own, or it comes co-formulated. It can't be prescribed with rifampicin. If you use it with rifabutin, you can prescribe it, but you have to double the dose. Doubling the dose with use with rifampicin doesn't achieve sufficient levels. It's been compared to efavirenz and to darunavir in the drive ahead and drive forward studies, and it was found to be non-inferior. It's well tolerated, fewer side effects than efavirenz, and fewer negative effects lipids than darunavir and as well. You do see weight gain associated with it. It's never been compared directly with integrase inhibitors. And because integrase inhibitors work so well in first-line therapy, it's unlikely to be advised as first-line initiation therapy compared to the integrase inhibitors. We have no information of its for safety in pregnancy, so it can't be used in pregnancy. And it's never been used in combination with TAF. It's never been studied in combination with TAF either. All right, so etravirine, we'll talk about etravirine briefly and then rilpivirine. Etravirine is the most commonly used in RTI for drug-resistant HIV. And the decision to use etravirine should be based on the resistance profile and the scores that you calculate from your resistance test. However, regardless of the score, it doesn't matter what your score looks like for your NNRTIs, etravirine always has to be used in combination with 2 active agents or multiple partially active agents. Otherwise, it's not gonna work. So if you use 2 or more fully active agents with etravirine, you're going to increase your chance of achieving virological suppression by 8 times. Also has significant interactions with cytochrome P450 system. If you use dolutegravir and etravirine together, because they're metabolized in similar, use a boosted PI as well. So you can't just use etravirine and dolutegravir together. You have to use dolutegravir, etravirine, and a boosted PI if that's what your combination is. This graph here is etravirine and dolutegravir together, and it shows a reduction in the dolutegravir concentration. And this is the graph with use with a boosted PI. Okay, so I just thought I'd show you here the Stanford resistance database. So I kind of wanted to do it live, but I was pretty sure it wouldn't work. So these are just screenshots of the site. The databases, this is the database that the NHLS uses to give you the information that you get in a resistance test. So you'll get high level, low level, intermediate resistance, and that calculation is based on this database. And then in addition, it will calculate a score for each agent that will help you to make a decision about a regimen for drug-resistant ART. So this is a patient who obviously has a resistance test, and I can see that you can't see the mutations, but there are, a few mutations: M184V, a G190A, an L76V. So these mutations in 3 different classes. So that's NRTI, NNRTI, and PI mutations. And then you take those mutations and you put them into the calculator, and the calculator will give you a pretty little picture that tells you where the mutations are along the genes, and then it will give you a score. So it will calculate the resistance mutation score, and you can in fact get a long list of the scores that you can print out. You can do the calculation manually, but apart from the time and the mental energy it takes to do that, the advantage of this calculator is that it kind of can give you a score of, so some mutations, when you see them in combination, will give you a different score as to when you see them by themselves. And that will do the calculation for you. So there is a DOH algorithm for choosing third-line ART. It's from 2018. I'm not showing it to you because it's out of date. It's going to be reviewed in the next couple of months. But if you were to look at these scores, you get a PI score of more than 15. So obviously, if it's a positive score, it means that there is resistance. If it's 0, it means that there's no impact of that mutation. And if it's a negative score, it means that it results in hypersusceptibility to an agent. So this patient has a PI score of more than 15, a darunavir score of more than 15, a tenofovir score of 15, an AZT score of 60, and a travarine score of 10. So what you would want to do is you would want to put in a drug that the patient has never been exposed to, and in this case, the patient has never been exposed to an integrase inhibitor. So you would start with an integrase inhibitor, then you would add a protease inhibitor that's a pretty good drug, and you would obviously choose darunavir because it has the lowest score. Then you would fill in the gaps with NRTIs, and you would choose the NRTIs that have the lowest score. So you would choose a TDF over AZT. You would always add 3TC. And basically what you end up with here is the third-line regimen that's recommended for the majority of patients in the 2020 HIV Clinician Society update. So there's no empiric therapy for third-line ART, but the vast majority of patients who need third-line ART are going to respond to a combination of TDF, 3TC, dolutegravir, and a boosted darunavir. All right, so rilpivirine, this is going to take us into a short discussion about long-acting ART. It's a small dose of a tablet, so it makes a small FTC when it's co-formulated with TAF and FTC. Can be taken, it has to be taken with food, and the meal needs to be at least 390 calories. And I Googled that, and that's like a KFC crunch burger. So you need to eat that much when you are taking your rilpivirine. It should only be used in patients who are treatment naive and who have viral loads of less than 100,000. So that is quite limiting. In the early trials, it was associated with virological failure more often with viral loads of over 100,000 than efavirenz. Subsequent trials, there's this trial called the STAR trial. And in the STAR trial, it was found to be non-inferior to efavirenz with patients who have viral loads of less than 500,000. But the registration is still only for use in patients who have viral loads of less than 100,000. It makes it it can't be used with TB treatment with rifampicin, and so that makes it a very difficult option for us to use here. And also, if you have to combine it with the need to do a baseline viral load, which is not generally recommended, but now if we were using rilpivirine, we'd have to do a baseline viral load, and that obviously adds significant cost to an ART program if you have to do viral loads on everybody before they start. So it's not really an ideal drug in our circumstances, but it does form one of the first it's an agent in one of the first regimens that have been investigated for long-acting ART. So a few years ago, I started getting questions from patients, when are the injections coming? And a few years ago, I'd have to say, look, they're a long way off, they're still in development, we'll have to see how they do. And now I can say, look, they're doing well overseas, they're being used in routine care overseas, it's just a matter of time before we see them here, and I'm hopeful that we will have access at some stage, but they're not in our future imminently. And then we need to think, who are the right candidates for long-acting ART? And for us, we always think, oh, it's the recalcitrant adolescents who don't take their ART, or it's the patients who just can't remember, or the patients who frequently miss their appointments. It's the non-adherent patients that we as doctors think would benefit from long-acting ART. And the original thinking is that, in fact, these are the wrong patients for long-acting ART, that it's really a good switch option for those patients who are already engaged with their healthcare, who are already suppressed on oral ART for 3 months or 6 months, and who are able to come to the clinic every couple of months for their injections. And most clinicians who use this strategy already stick to that recommendation. So that's where the evidence is that it works well in patients who are already suppressed. But there does seem to be emerging evidence that it can be used in first-line patients. It can also be used perhaps without an oral lead-in. So now we're very keen on same-day ART initiation. And if the patient can come to the clinic, you diagnose them with HIV, you give them a jab in the bum and you send them on their way. Or it can be used now as alternative therapy in patients who are not virologically suppressed. So what are our long-acting options? So the options aren't extensive, but you got to start somewhere. So firstly, there's a combination of cabotegravir and rilpivirine. So FLAIR was an early trial. It was a phase 3 open label trial. It compared an oral integrase inhibitor regimen to CAB rilpivirine in patients who were ART naive at the start. But they all got 20 weeks of dolutegravir-based regimen. So it was dolutegravir back of a 3TC. They all got 20 weeks of that. Those patients who were suppressed at 15 weeks were then continued into the injectable trial. But all of those patients also got an oral lead-in of CAB rilpivirine. They took their 3-drug regimen. Some patients carried on with that 3-drug regimen. Then the second arm got an oral lead-in of CAB rilpivirine. And the obvious reason for the oral lead, cabotegravir or rilpivirine, now you've given them the injection and you can't get it out of them, and what are you going to do? So that's the reason for the oral lead-in. And the injectable regimen was found to be non-inferior to the oral regimen with viral loads over 50 in only about 2% in both arms at assessment of the primary endpoint. Then the Atlas trial was an open label trial, also a phase 3 trial. It recruited participants who were already suppressed on oral ART. So they were, in the clinic, they'd been taking oral ART and they were already suppressed. They were then randomized to continue either their oral regimen or switch to a monthly injection of CAB rilpivirine. They again had a 4-week oral lead-in. And the primary endpoint at 48 weeks showed that their regimen was non-inferior. So then at the end of that maintenance phase, they were then invited to continue into the Atlas 2M trial or to continue into the extension phase. So they were either switched to the injectable arm, they could continue with, so they were either switched to the injectable arm or they could continue into the 2M trial, which was the injection every 2 months. The 2-month regimen is non-inferior to the 1-month regimen, and predictably patient prefer injections every 2 months rather than every month. They are quite large injections, so they come separately. They're not in the same, they're not mixed together. If you come every 2, it's a 2 ml injection in 2 syringes, so it's 4 mils. If you come every 1 month, it's 2 mils. If you come every 2 months, it's 3 mils. So you get 3 mils in one bum and 3 mils in the other bum, which is quite a big injection. And it's quite uncomfortable. And obviously the most common adverse event is injection site reactions. The Atlas trial also identified some potential risk factors for failure of the regimen, and they were pre-existing rilpivirine resistance mutations. So interestingly, not integrase inhibitor mutations, but rilpivirine resistance mutations, an HIV subtype of A6 or A1, which we don't really see here. Our subtype is mostly C, and then a BMI of over 30. And because this is an intramuscular injection, if your BMI is over 30, you may not get it into the muscle. So the solution really to overcome that is to use a bigger needle. And that's what people who use it in practice often do. So those are the 3 risk factors, but really you need more than 2. You need, well, 2 or more of those risk factors for it to be associated with virological failure. Okay, and then there was an extension of the FLAIR trial as well that allowed participants to either withdraw, to continue with their injectables, or change from the oral arm to an injectable arm, but with or without the oral lead-in. So the previous trials really didn't identify any safety signals when it came to cabotegravir and rilpivirine. So most patients tolerated it very well. Nobody was allergic to it. So they thought, well, can we go straight to injections when we're changing patients' medication? And it showed that the direct-to-injection option was, achieved similar safety. It had similar safety profiles. It achieved the same pharmacokinetic profiles, and it worked just as well. Okay, so there was no decrease in efficacy. So the current approvals for this combination are for 4-weekly injections, for 8-weekly injections, and with or without an oral lead-in. So you don't have to have the oral lead-in, but you can use it. And then there's another recent study called the SOLAR study, which has compared bictegravir to this option, and the results are essentially the same. So the next question is, what about using long-acting CAB rilpivirine as switch therapy for patients who are not suppressed on ARV? So for the clinicians, we feel like that's really the group that we need to target. And a group in Ward 86, which is apparently the oldest HIV clinic in America, it's in San Francisco. And they initiated a project to see if CAB rilpivirine would work for those patients who were unsuppressed on their oral ART. And that group of patients constitutes about 10% of the clinic. And I think that's probably similar for us. They also describe their clientele as a high-risk population with significant psychosocial and economic vulnerability. And I also think that that describes a large proportion of our population as well. So the long-acting option was offered to these patients. They got a group of patients who were suppressed. They got a group of patients who were unsuppressed. And they were given a direct-to-injection option. They thought that that was most likely to be successful. So that was the option that they favored. And then, in addition, those patients who had detectable viremia were given quite a lot of support. So they had sort of individualized support. A lot of these people were homeless, so they were put in contact with street nursing facilities. So people who, nurses who go out onto the street and deliver medication and so on, links to community injection sites, home care as well. So they did receive a lot of support. There were 15 patients who started out as unsuppressed. 12 of them suppressed completely, and 3 had a 2-log decrease in their viral load by the end of the first month. And 2 of those patients were patients who'd been on ART for 10 years and had never had an undetectable viral load. So it seems to be that although the registration is for switch therapy or initiation therapy in patients who are virologically suppressed, in patients who have virological failure, it seems to work well as well. So then lenacapavir is a first-in-class drug. It's a brand new drug with a new mechanism of action. It's an HIV capsid inhibitor. It comes as a weekly tablet, and it comes as a long-acting subcut injection, and it can be administered every 6 months. It works in 3 ways. So it works in multiple points of HIV replication. So it inhibits the capsid-mediated transport of proviral DNA into the nucleus. It inhibits protein subunit formation, and it accelerates capsid formation, which results in abnormal capsid structure. So it works in various different ways. The original trial was the Capella trial. It included highly treatment experienced patients who had multi-drug resistant HIV and virological failure. Those patients were observed during the screening period, and then they were divided into 2 cohorts. So cohort 1 was a group that maintained stable viremia above 400 copies. And then those who had decreasing viral load over that functional monotherapy. So they were kept on their failing regimen. They were given lenacapavir, and that was compared to placebo. And not surprisingly, lenacapavir performed better than the placebo. And then in the second cohort, the patients were changed immediately to an optimized background regimen, and they started the oral lenacapavir. Ultimately, all patients in the study received injectable lenacapavir plus an optimized background regimen after day 15. And at 26 weeks, 81% and 83% of patients were suppressed overall. So in relation to the companion drugs, so if you had 2 or more fully active agents in the regimen, you achieved suppression in 94% of cases, and in 67% of cases in which there was 0 fully active drugs. So so it does seem to be a good option. It's a nice option because it's a 6-monthly option, but obviously there are no other 6-monthly options available at the moment, so you would have to combine it with other drugs. And a trial of lenacapavir treatment-naive patients is currently underway. All right, so what's in it for the patient? Why do patients want to take long-acting antiretrovirals? So one thing that comes up a lot is that they don't like being reminded of their status on a daily basis. So if you have to take your ARVs every morning or every evening, every time you take your ARVs, you think, oh my God, I'm HIV infected. So if they have an injection, they don't have to have that reminder every day. Patients like not having to hide their pills. Not everybody is out to family and friends, and they don't have to worry about somebody, having a look in the cupboard and seeing their pills. They like not having to plan to take their pills away with them when they travel and make sure that they've got enough when they travel, and they like the convenience. So are there any downsides to long-acting antiretroviral? What are the challenges? So there are obviously cost implications in our settings. So we would have to determine whether or not the HIV genotype was going to respond. So if it was A1 or A6, in our setting we have mostly C, and maybe we could just take the chance, but obviously that wouldn't be really advised. So you'd have to determine the HIV genotype. You'd have to determine whether there's rilpivirine resistance present. So you would have to do a resistance test in all those patients. At present, it's not recommended for use in pregnancy. So you would need to make a plan for patients who become pregnant while on the injectable regimen. You'd have to switch them to an oral regimen. It's also not approved. So cabotegravir is not approved for use in pregnancy. It is being used in PrEP trials. And in the PrEP trial, the FTC for preventing HIV, cabotegravir by itself works very well. There hasn't been any pregnancy signal that looks like it's unsafe in pregnancy, but we don't have enough information. Patients would need to be able to stick to their 2-monthly schedule of visits. So they'd have to come every 2 months. At the moment, we see our patients every 6 months. Are they going to be prepared to come now every 2 months instead? We give their ARVs at Dischem and Clicks. Maybe Dischem and Clicks could give them their injections. Obviously, that regular visit is overcome by a 6-monthly schedule, or if the injections could be self-administered. If the injections can be self-administered, obviously, then we would have to determine whether or not patients can store the medication appropriately. And also, as the HIV population starts to age and they start to use a whole lot of other medications, is it going to be any advantage to them to get their ARVs as an injectable if they have to take a handful of other pills in the morning anyway? Also then we need to consider patients who travel. So migrants, people who go home for a long period of time, if they're supposed to come back at 2 months for their injection and they're only going to come back 3 months later, are they going to be switching from oral to injectable backwards and forwards frequently? And what are the implications of that? We don't really know yet. All right. Thank you very much. I'm done. Are there any questions?